Good morning, everyone. Thanks for having me. So my research has always been focused on pancreatic cancer. So this is close to my heart, but I will try to sprinkle in a little bit of precision oncology today. So these are my conflicts of interest, and today I'm going to present two trials that I'm PI of and that I have advised on, and I will mention that later on in the talk. So just to briefly give you an idea where we stand today in terms of metastatic pancreatic cancer and the options with regards to systemic therapy, in 1997, with a pivotal trial, gemcitabine became standard of care and stayed standard of care, one has to say, for almost 20 years, because gemcitabine erlotinib, which was approved by the FDA and the EMA in 2007, really made only little impact on the survival of pancreatic cancer patients. FOLFIRINOX was a big step forward in metastatic pancreatic cancer, and it should read 2013 for gemcitabine and nab-paclitaxel. So these are the first line regimens that we use today. And then there's data for the off regime, which was published in 2014, and the Napoli regime in second line. Sorry, I got my numbers wrong. That was 2017 as a second line option here. So this is just all of the regimens that we use are standard chemotherapeutic agents, and I feel that we need to move forward in order to improve on the outcome of pancreatic cancer patients. We did similar assumptions for Germany with regards to the rise in pancreatic cancer cases, and by 2025, pancreatic cancer will become the second most common cause of cancer-related death in Germany and in most Western countries. So we really need to do better than just staying with the same sort of chemotherapeutics that we've been using for years. And I would like to try to answer three questions. What are potential ways forward? So I feel that we need to run trials that really answer the pressing questions in pancreatic cancer, and I will allude to those in a moment. We really need to improve screening for clinical trials, and that's why advocacy groups such as DiCE are so important. And one road that I find particularly interesting is a focus on relevant subgroups in pancreatic cancer, because those exist and they become bigger and bigger by the day. So the problem in pancreatic cancer is that we have a riddle wrapped in a mystery inside an enigma, like Dan van Hoff said a couple of years ago. We know that this disease is increasingly resistant against all of the therapeutic options that we have. It tends to relapse even after curative surgery. And what is important, we also do not really understand which patients respond to our treatment and which patients do not. So that's why I believe it's really important to educate about these questions and name the problems when talking to peers, but also when talking to your patients, that they understand why this disease is so deadly and why we've made little progress in the last 40 years. I would like to give you two, and this is one of the trials that I alluded for that I'm a PI of. I would like to explain a little what I mean with regards to relevant trials. Currently in Germany, we're running a 3-arm phase 2 clinical trial where we randomize between the standard of care gemcitabine and nab-paclitaxel, and then Napoli, so FOLFIRI, and sequential Napoli FOLFOX, which is sort of a FOLFIRINOX. On the first side, this is a very simple trial and it's not really interesting enough. Although the question in medically fit patients, should we start with gemcitabine and paclitaxel or a 5-FU-based regimen, has not been answered before. But what this trial will help us, and that's why I consider it not only because I'm PI, a smart trial, is that we are going to have signatures, molecular data, helping us to explain which patients might respond better to gemcitabine therapy than to 5-FU and vice versa. And this can only be done in the setting of a clinical trial. The second trial that I would just want to show you for a brief moment is in resectable pancreatic cancer. We don't know which patients actually benefit from resection and in the end from adjuvant chemotherapy. There's good retrospective data that patients that have circulating tumor DNA before surgery will relapse very, very soon. And maybe this intensive upfront resection is not the right option for them. So what we're doing in the projection trial is that we try to really nail down is liquid biopsy ctDNA positive positivity before potential curative surgery, a marker that will tell us these patients do not benefit from upfront surgery, but could undergo perioperative treatment, or maybe those are patients that do not undergo surgery at all because they have a cold metastatic disease. Next, I would like to highlight that it's really important to improve clinical trial screening. This is data from the MSKCC Impact Program, where every patient undergoes comprehensive genomic profiling being treated at this institution. And what that does is that you are able to ramp up enrollment into clinical trials significantly. Usually at good centers, this number is at 5%, and it's far higher at MSKCC, but those are only patients enrolled into molecularly guided clinical trials. And by screening large numbers of patients, you're able to add innovative treatments to patients. There are a lot of naysayers that say, well, pancreatic cancer patients do not have any benefit from these innovative agents. And to that, I would say, so this is data for the NTRK inhibitor entrectinib. And in the entrectinib trial, patients with PDAC also benefited from trial with this novel agent. And why is this important? This is data currently under review, which we compiled. We are going to see so many new and exciting drugs entering the market in the next 5 years. And in these trials, pancreatic cancer patients are usually underrepresented, but these are drugs that could really have a benefit across multiple entities, including pancreatic cancer. So it's really important not to be nihilistic about helping patients with pancreatic cancer undergoing comprehensive genomic profiling, for which, in most cases, as for the inclusion into a clinical trial, you need a tumor biopsy, regardless of the clinical presentation. So helping to improve clinical trial screening is super important in the end. And I apologize that these slides are in German, but I'm going to allude to a program that we have built in Munich. It is really important to connect your experts and your clinical trial platform to treating oncologists outside of your center, outside of your hospital, because they tend to run pathology reports. They have access to the patients, but they don't want to send their patients to a center. So we have established a virtual molecular tumor board and can now access cases. So the molecular pathology report is directly sent to my team. We look at those reports, we check our study platform, we talk to our experts, and we give this information back to the treating oncologist, who can then discuss with their patients. And with this program, we have more than 20 private practices, large hospitals in our network. And this opens up trial screening on a larger scale. So the last thing that I would want to make clear, and this is where I see hope, is that we need to focus on relevant subgroups in clinical trials. And the first subgroup I would like to allude to are patients with BRCA mutated pancreatic cancer. There's a lot wrong with the POLO trial. But what I feel is really, really important is not the maintenance with olaparib in these patients that have stable disease under platinum-based chemotherapy, but how long these patients can live with simple platinum-based chemotherapy. So this is data from Eileen O'Reilly's group showing you that patients that receive platinum-based chemotherapy in the first line setting, this is important. This effect is lost if you treat with platinum in the second line, have 10 months median progression-free survival and a median overall survival of 15 to 16 months, which you do not necessarily see in metastatic pancreatic cancer. There are other subgroups, and one of them would be patients with KRAS wild-type disease, somewhere in the range, depending on which population you look at, but especially in young patients, up to 8% of pancreatic cancer cases. And these usually are driven by so-called fusions, when one gene fuses with another and a new gene arises. And these fusions are sensitive to targeted treatments. And data has been shown at this year's ASCO that was really, really encouraging and was focusing on pancreatic cancer patients. So knowing if your patients have RAS wild type or RAS mutant disease can make a huge difference. And then, not surprisingly, this is a patient of my own. A very important subgroup, maybe 1 to 2% of our pancreatic cancer patients are patients where DNA repair does not work, so microsatellite instability. This is a patient with Lynch syndrome that was referred to me from another hospital where they had recommended him to go to hospice care after progressing on FOLFIRINOX. And we found out that he had Lynch syndrome and filed for immunotherapy. And this is not after what the radiologist read as liver resection. This is just all of the tumor that encompassed his left liver gone through treatment with an immune checkpoint inhibitor. And this guy is now living without any signs of pancreatic cancer for almost 3 years and is back to work and will become 40 this year, I believe. So I would like to conclude today that it's really important to support and educate patients that they're able to identify smart clinical trials. Any clinical trial, I believe, is better than being outside of a clinical trial, but being in a smart clinical trial is the best. And help them with screening for clinical trials. In a lot of cases, oncologists will be reluctant to offer comprehensive genomic profiling, for example. And a lot of these trials will be closed if you are not able to do so. And then the last thing that I mentioned is that we really have to focus on relevant subgroups. And with this, I am very happy to discuss what we've just seen. And thank you again for the invitation.